All right, well, thank you everybody for welcoming me back. I was here on Wednesday talking about part one, supportive care. And then I think yesterday you got to meet my colleague, Dr. Matt Newman, who practices in inpatient in our leukemia service. He talked about some of the other supportive care issues we see in oncology. I believe, correct me if I'm wrong, I'm the first lecturer to go into the therapeutics of some of the main cancer types. So you're going to have lung cancer, prostate cancer, breast cancer, and then leukemias, I believe. Okay. I'm going to start off by saying I know this material is overwhelming. Okay. I know that it is. I know that all of the therapeutics lectures are going to be a little bit overwhelming. Oncology can be a tough topic to dive into. I'm going to try to highlight the things that I would expect you to take away from the material. Okay. It's really hard to simplify and kind of do an introductory lecture on lung cancer without being inaccurate. So I tried my best to highlight where I think you as a learning pharmacist would need to be able to identify things that pharmacists do in practice. So I'll be very clear when I think this is an important slide or something that you need to know. So without further ado, let's get started. All right, so today we're going to be going through the epidemiology and screening for lung cancer. We're going to go a little bit into diagnosis and staging. As a pharmacist, you don't diagnose patients with lung cancer and you don't stage patients with lung cancer. However, in order to understand the therapeutics and when we use which therapies, you do have to have a background knowledge of this, okay? So I think each of my colleagues in breast cancer, prostate, and leukemia will also do an introduction to diagnosis and staging. It's more so to get the big picture than it is for us to necessarily test you on these, like any material from diagnosis and staging. We're then going to talk about small cell lung cancer, which is perhaps the easier to digest. So we'll warm you up as we go into the material. I'll give you a break after small cell, and then we'll go into non-small cell lung cancer, which is a bit more complicated, but also makes up the majority of our lung cancer cases. And then finally, I'm going to introduce immunotherapy, which is not specific or unique to lung cancer, but I'm going to introduce a lot of the sort of the mechanism of action of this. So I guess it's an entire like spectrum of therapies, and then some of the adverse event management specific or unique to immunotherapy. This is just a list of the drugs that are going to be introduced within this lecture. When I say platinum doublet chemotherapy, it refers to cisplatin or carboplatin. So those are the platinum agents that we tend to use in lung cancer, in combination with one other chemotherapy agent. That's where the doublet comes from, right? So two doublet, one of the agents is cisplatin, carboplatin. The other one is either pemetrexed, paclitaxel, docetaxel, gemcitabine, or etoposide, okay? And my understanding is this is not the first time you're hearing these drugs because you've had an introduction to the pharmacology of some of these agents. For immunotherapy, I've listed the immunotherapy agents that we'll talk about in this lecture. Atezolizumab and durvalumab are PD-L1 monoclonal antibodies. Semiplumab, nivolumab, and pembrolizumab are PD-1 monoclonal antibodies. Ipilimumab is a CTLA-4, and then tarlatamab is our first BiTE therapy in solid tumors and small cell lung cancer. For the targeted therapies, there are many targeted therapies in the treatment of lung cancer. This is one of the reasons why I personally love lung cancer. This is my practice area because it is a very genetically driven disease, and there are a lot of mutations in lung cancer that we now have drugs to target, which is really cool. We don't have time to go over all of them or even introduce most of them. So we're only going to be talking about the two major targeted therapy drug classes, EGFR inhibitors and ALK inhibitors, okay? And for the pharmacology, it's my understanding that erlotinib and crizotinib were some of the example agents, but the listed drugs are all the drugs in the class. The test material is going to be taken directly from these objectives. So I want you to be able to recall the recommended first-line treatment for patients with extensive stage small cell, identify the role of osimertinib in the adjuvant treatment of early stage non-small cell, understand how to interpret PD-L1 and mutation testing in order to create or evaluate a plan for the first-line treatment of stage 4 non-small cell, identify the characteristics of patients who are likely to harbor an EGFR mutation, and be able to speak to the class side effects of EGFR TKIs. Recall the class side effects of ALK tyrosine kinase inhibitors, and then understand how immune checkpoint inhibitors work, as well as contraindications to use and how to manage some of the immune-related adverse events. This is a glossary because I'm going to have to use a lot of abbreviations, or you're going to see a lot of abbreviations on your slides. This is them all spelled out for you in case you don't know what something means on a slide. It should be contained here. All right, let's talk a little bit about the epidemiology and screening. So lung cancer is the most deadly cancer in the United States. It's the third most common cancer, second to breast cancer in women and prostate cancer in men. But again, it is the leading cause of cancer-related deaths. And that is by and large because of the later stages in which the cancer is usually diagnosed. In 2024, it represented about 12% of all new cancer cases in the United States. And these top 10 have kind of stayed pretty stagnant over the last several decades. So as far as incidence goes, these change slightly from year to year, but the order and the cancer states that you see here have stayed the same. The good news is that although there are still a lot of deaths from this disease, survival rates are increasing. You can see from the graph on the left that over the last 5 to 10 years, we've seen significant improvements in the 5-year survival rates. But overall, the relative 5-year survival is only around 27%, okay? So that is the percentage of patients who are alive 5 years after diagnosis. So lots of room for improvement. You can see that the stage of diagnosis greatly impacts the likelihood of somebody being alive at 5 years. So when we have localized disease, about 64% of people are alive at 5 years. That drops to about 36% if there's regional lymph node involvement, and then it plummets to less than 10% when we have distant or metastatic disease. We do have methods for screening for lung cancer. The screening modality that we use is low-dose CT screening or computed tomography screening. And the data to support this comes from the National Lung Screening Trial. So this was a huge effort. It was more than 50,000 patients who were identified as being at risk for lung cancer. They were enrolled onto this randomized multi-center clinical trial, and they were randomized to either chest X-ray or low-dose annual CT screening, okay? The patients that they enrolled and defined as at risk for lung cancer were between the ages of 55 and 74, because we do know that cancer is a disease of the aging or elderly, right? And they had to be current or former smokers, having at least a 30-pack year history. If the patients had quit smoking, they had to have done so within the last 15 years, okay? So we're looking at either active smokers or people who have only recently quit smoking. And what we found was that there was a significant improvement in the reduction in lung cancer mortality. So low-dose annual CT screening reduced lung cancer mortality by 20%. But the number of people that you had to invite to get screened in order to prevent one death from lung cancer was 320. So that's pretty big, right? And so from a large kind of like population health standpoint, that's a lot of people that need to undergo screening in order to prevent one patient from dying from lung cancer. So this has been slow to be adopted in the United States. Our compliance with screening people who should be screened is pretty low. It's around 5 to 10%. It is increasing, but the problem is that the people who need to know this and know who to screen are primary care physicians, and primary care physicians are generally the people who have the least amount of time with their patients, are very strapped for being, time and vaccines and preventative health, et cetera, and aren't always adequately identifying somebody who could benefit from screening and recommending that they get low-dose CT scans. The other thing is that there has to be adequate follow-up. If there's anything suspicious found on the low-dose CT scan, that person needs to be referred to a clinic, a lung nodule clinic, in order to be followed over time and potentially referred for biopsy if there's anything suspicious. So these are the screening guidelines of who we now recommend screening. We have expanded the population that was in the National Lung Screening Trial to 80 years, and that's because people are living longer. And then we've shortened we've expanded on the lower end to include people that are 50 years. Partially, that's because that's an easier number to remember for primary care physicians. So anyone between 50 and 80. They have to have now only a 20 pack year smoking history, and it doesn't matter if they've quit. So it's no longer required that they have a certain number of years since quitting. And when I say the word pack years, I want you to be able to calculate what that means. To have a 30 pack year history is to smoke 1 pack a day for 30 years, or to smoke 2 packs per day for 15 years, or to smoke a half a pack a day for 60 years. Okay, does that make sense? It's like the number of years smoking relative to packs per day. All right. Just go briefly into diagnosis and staging. So how does a patient who is suspected of having lung cancer usually present to clinic? First and foremost, patients usually have a cough. Okay, it's very, very common that people will have a several week to several month history of chronic cough that does not seem to be getting better. Most often, that person will go to their primary care physician. They'll say, I have a cough. The doctor will say, okay, you probably have a virus, or you probably have pneumonia. They'll put them on 2 weeks of antibiotics. The patient probably won't get very much better. They'll come back to their primary care physician. Primary care physician will say, all right, let's try a different antibiotic. They'll get put on another 2-week course. And when it's persistent beyond that is typically when the provider will order more advanced imaging. Sometimes our patients will actually be coughing up blood. That's hemoptysis. When that occurs, that's usually more of a red flag and prompts a little bit faster action on the part of the primary care physician. People can have labored breathing or difficulty breathing. That's dyspnea. They can have pain, especially at the sites of metastases. So if we have the cancer that metastasized to the back, the patient might be reporting a several months history of back pain that's unrelieved with any kind of measures such as ibuprofen, Tylenol, stretching, physical therapy, et cetera. They might have weight loss, and they might have a decreased appetite. But unfortunately, most of our patients actually are not going to have any symptoms at all. And we still have a high number of cases that are either incidentally caught when they come in for something else, or they're very late stages when they develop, and again, they come in for some other reason, and we kind of find the cancer incidentally. All right, I mentioned previously that the survival really does depend on what stage the cancer is diagnosed at. This tells you the percentage of cases that are diagnosed at each of the stages. And kind of the big picture take home here is that the majority of cases are diagnosed at stage 4 or metastatic. So you can see that more than 50% of cases are diagnosed when the cancer has already spread and metastasized to other organs. We've seen over time that improvement in survival that I showed you on that prior graph, it's really because we are shifting more to better screening. So we're appropriately screening patients and catching these cancers before they're symptomatic. And we're seeing a higher number of stage 1 cases because of that. So some of the improvements have been due to that, and some improvements have been due to better therapeutics. But still, again, a lot of room for improvement because the majority of patients are presenting at an incurable state. Okay, so what do we do when we have a suspected lung cancer case? A pretty catchy, not really acronym, but a catchy phrase is name it, stage it, treat it, okay? Because those are the 3 things that you have to do in order to develop a therapeutic plan. To name it, you actually have to get tissue and biopsy it, okay? You can't just look at a CT scan and say, that kind of looks suspicious. That's not supposed to be in the middle of the lungs. The lungs are supposed to be black there, which indicates air movement. You can't just look at a CT scan and say somebody has cancer for sure, okay? There's lots of benign things that can cause lesions in the lungs. Very commonly, people, especially people who are not born in the United States, can have granulomatous disease from various infectious diseases like non-tuberculosis mycobacterium and things that are more prevalent in other parts of the world. So you can't assume it's cancer. You have to actually stick a needle in it, and you have to biopsy it and confirm that it's malignant by pathology. You also want to know, where did this cancer, if it is now deemed to be a cancer, originate? Just because there's a mass in the lungs does not mean it's primary lung cancer, okay? That could be a metastasis from sarcoma, that could be a metastasis from breast cancer. So you have to identify the tissue of origin, and that is also done by the pathologist. And then in lung cancer, because we use different chemotherapy regimens based off of histology, we have to determine whether something is of squamous histology or of adenocarcinoma or non-squamous histology. So we need to be able to characterize it in that way. The second thing we have to do is stage it. How advanced is this cancer? Is it just confined to the lungs? Has it spread to the local lymph nodes, or has it spread to distant sites of in the body? So you have to be able to stage it. And then finally, to come up with a treatment plan, it's generally a multidisciplinary effort. So it's an effort on the part of the medical oncologist, the pathologist, the radiation oncologist, and the surgeon, okay? And we'll talk about that. And whenever we're coming up with a treatment plan, we always have to account for the performance status of the patient. That is, how functional is the patient? How much loss of function have they had relative to their baseline? And then what comorbidities do they have, right? Because maybe somebody has a more, localized cancer, but they have multiple medical comorbidities that's going to impair our ability to give them optimal treatment. Okay, this is an introduction to staging. Again, I'm not going to ask you to be able to stage a patient, okay? But you kind of have to have a little bit of an appreciation for this. We use the AJCC 8th edition for staging currently. The 9th edition did launch in January of this year, but all of the clinical trials that inform our treatment approaches currently are based off of the 8th edition of staging. So that's what I'm going to show you today. And there's only minor changes from the 8th to the 9th edition. So it's mostly not relevant for purposes of teaching at this level. Okay, so when we do staging by AJCC, we use the TNM classification. I'm not going to be the first person that's talking to you about TNM staging. My breast cancer colleague and my prostate cancer colleague are also going to talk to you about that, okay? In solid tumors, T stands for tumor, N stands for nodes, and M stands for metastasis, okay? So the T stage describes the location and the size. How many centimeters is it, okay? And the higher up you go, from T1 to T4, the larger the cancer is, or the more advanced it is, meaning it might have invaded into nearby structures. The N stands for nodal metastases or lymph nodes. We use the classification of N0, which means no lymph node involvement, N1, which means same side lymph node involvement within the pulmonary, intrapulmonary nodes. N2 means same side, but now they're in the mediastinum or the subcarina. And N3 means contralateral or opposite side. And this is relative to the tumor, right? So if I have a right-sided tumor and I have lymph nodes on the right, that's ipsilateral or same side. If I have a right-sided tumor and I have left-sided lymph nodes involved, that's contralateral. And then finally, the M stands for metastasis. It's M1 if the metastasis is all confined to the thoracic cavity, M1A if it's all confined to the thoracic cavity, and then it's M1B if there's a single site of extrathoracic metastasis, and M1C if there's multiple sites of extrathoracic metastasis. So we put all the T and M staging together, and then we determine the stage of disease, okay? So staging ranges from stage 1A, which is the most localized, easiest to cure, all the way up to stage 4, which is incurable, okay? Again, I would not expect you to be able to do this. I would not expect you to memorize this. I don't have this memorized. There's no point. You can easily look this up, but I do want you to kind of understand how the staging progresses, how it might be more advanced. You can see that stage 2B is where we start to get that N1 disease. So now we have lymph node involvement. And then when you hop to stage 3A is where we might have N2 lymph node involvement. That's our mediastinal lymph nodes. And then finally, stage 4 is going to be the first stage, excuse me, where we have distant metastases or metastases within the lung cavity, thoracic cavity. Well, why do we stage a patient? What's the point? Why does it matter? What does calling something stage 1, stage 2, stage 3, what does it mean? There's two reasons. One, it helps us to inform treatment decisions, but mostly too, it helps us to prognosticate and give the patient an idea of what their survival is going to look like, okay? So on this graph, you can see the 5-year overall survival based on stage. And you can see that patients that have stage 1 disease have like a 70 to 90% chance of being alive at 5 years. Versus our stage 4 patients have, again, a less than 10% chance of being alive at 5 years, okay? So it's important to be able to guide the patient in helping them to understand kind of what their survival might look like, and also to help us decide how aggressive we need to be with treatment, okay? I will just say that not everybody falls, there's exceptions to every rule, right? And that's very true in oncology, okay? So just because somebody has stage 4 lung cancer does not mean that they will definitely be dead in 5 years. There are outliers, and I have a lot of patients in my clinic that are outliers, but it does kind of help to give patients this data so that, again, they can help make important decisions for their life and what they want to do as far as treatment. Okay. So let's briefly just introduce some diagnostic modalities. You're going to see these once you go into clinical rotations, both inpatient and outpatient, not even just in oncology, but some of the ways in which we gather information when we're working a patient up and trying to figure out what's wrong. In the pathology or lab evaluation, you might see a core needle biopsy or a fine needle aspiration. Those are two different ways to go in and name it. Remember, I said name it, stage it, treat it. That's where you have to get the tissue. So either fine needle aspiration is putting an itty bitty teeny tiny needle in, or core biopsy is kind of getting like a core sample, a much larger sample of tissue. Both of those send material off to the pathology lab for the pathologist to render a diagnosis. We also need to kind of work towards staging the patient. And to do that, we do CT scans, PET CT scans, and MRI or magnetic resonance imaging, okay? These are ways in which we assess where there might be other sites of disease in the body. Then finally, we might need to get additional tissue, especially when the patient has disease outside of the chest, or we need to get a larger sample than just a needle biopsy. So they can do CT guided, where they actually send the patient over to interventional radiology, and they have the patient under with CT guidance. They will be able to stick the needle precisely where they need to or where they think the cancer is present. They can do a bronchoscopy where they can actually put the patient under sedation, stick a little camera ultrasound wand with the needle on the end through their airway and be able to access tumors that are off of the main airways in the lungs. And then finally, a surgical biopsy. We typically do that when we have to have a larger volume of a biopsy. And then with molecular evaluation, we're doing immunohistochemistry, polymerase chain reaction, fluorescence in situ hybridization, or NGS. This is basically testing that's done by the pathology to give us more information about the tumor. I want to briefly touch on liquid biopsies because this has revolutionized the treatment of cancer. Okay. What is a liquid biopsy? We have learned that cancers shed DNA into the bloodstream, okay? So especially when the cancer is more advanced, like stage 3, stage 4, the cancer can be shedding DNA into the bloodstream, and we can send the patient over to the phlebotomy lab and get a blood draw with a simple blood draw, non-invasive, right? And they can send that off to the pathology lab where they can isolate the DNA from the tumor, and they can do testing on this DNA to determine if there's particular mutations or characteristics present. So some of the advantages are that maybe the patient's not well enough to undergo sedation and get a biopsy. Maybe they're not well enough to get anesthesia. This could potentially be a way to get more information about the tumor that's as simple as a blood draw. Some of the issues with it, though, is that it doesn't have 100% sensitivity. So just because we don't find valuable information in the DNA from the liquid biopsy doesn't mean that there's not like that particular mutation or biomarker of interest in the actual tumor. So if you find something in the liquid biopsy, you can trust it. So there's near 100% specificity, but it's not 100% sensitive. We also cannot tell histology, like we cannot tell the cell type because it's more fragments of DNA, and we can't test PD-L1, which is an important biomarker that we need to make treatment decisions. Okay, when I talk about biomarkers and molecular evaluation, what am I talking about? Okay, biomarkers are characteristics of the tumor that help us to determine the best treatment. It's really important that any patient with lung cancer, especially non-small cell lung cancer, undergoes this molecular evaluation to really be able to accurately characterize the cancer type. So some of the biomarkers that we see are PD-L1 immunohistochemistry. We're going to need that for everybody, regardless of whether they have squamous or non-squamous histology. And then there's a whole host of other molecular biomarkers that we look for. I told you that we don't have the time to go into those, and I'm not going to address all of them. But do note that EGFR and ALK, which are two of the mutation subtypes that I do expect you to have familiarity with, they're listed here, okay? So any patient with non-squamous histology, they really need to have their EGFR and ALK status evaluated before we formulate a treatment plan. And what are all of the tools that we have available to us to treat lung cancer? Surgery, right? That's one of the oldest methods. So we can surgically resect the cancer. We have chemotherapy, which is kind of non-specific, kills rapidly dividing cells, of which cancer cells are included, but also some are healthy tissues. Radiation treatment, which can be given for both palliative or curative intent purposes. Immunotherapy, which utilizes the patient's own immune system to better target the cancer, and then targeted therapies, which are typically tailored to those biomarkers that we talked about. So these are all of the different tools that we have available to us. First, surgery. How do we determine if somebody's a good surgical candidate? There's kind of two factors, right? One is the cancer actually surgically resectable, and then the second is the patient themselves a good surgical candidate, right? So you can imagine somebody that has terrible lungs, a lot of emphysema, COPD from heavy smoking history. We can't really take away a whole lobe or one whole lung and expect this person to have any sort of quality of life or be able to have good enough pulmonary function after the surgery in order to live. So if the patient's lungs are in really terrible shape, we may not be able to do surgery. If their performance status is too poor, like if they're bedbound most of the day, they're unlikely to really benefit from surgery. If they have terrible cardiac function, so if the patient's ejection fraction, if they have congestive heart failure and they're not able to undergo anesthesia, that's going to be limiting. And then really important, as I mentioned, is the cancer resectable? Can the surgeon go in and say, yes, I'll be able to get all of the tumor with clear margins and be confident that I didn't leave any cancer cells behind? Because if the surgeon is not confident that they can remove all of the visible cancer, there is no point in the person going under the knife and risking the morbidity and mortality associated with surgery, because it's not going to improve their survival, okay? If you left cancer cells behind, the surgery is not going to benefit the patient. And then finally, what does the patient want, right? We have some patients who are surgically resectable, but are adamantly against surgery. So does the patient even want surgery in the first place? I think this is important just because you kind of see these terms in the literature. Everybody knows we have two lungs, right? Right and left, 5 lobes, right? 3 lobes on the right, 2 lobes on the left. Right upper, right middle, right lower, left upper, left lower, okay? Everybody in this room could probably have an entire lobe taken out and be fine. I bet everybody in this room could have 2 lobes taken out and be totally fine. I don't know all of you, but I would bet 95% of us could have 1 whole lung taken out and still be okay, right? But think about somebody who has emphysema and really bad lung function. They're not going to be able to tolerate a bilobectomy or a pneumonectomy, okay? So when we take out 1 whole lung, it's called a pneumonectomy. If we take out 1 whole lobe, it's called a lobectomy. If you take out what's called a sublobe or do a sublobar resection, that's either a wedge resection, which is kind of like taking a little pizza pie slice that includes the tumor in the pizza pie, or a whole segment. And there's anatomical segments that are shown in the colorful picture on the right. Okay. So again, that's the decision of the surgeon. The surgeon looks at the imaging and says, I think I can resect this. It's going to be this type of surgery. And then they look at the patient's pulmonary function test and the patient's desires and say, okay, this is what I would have to resect. This is what I think your performance status and lung function is going to be afterwards, right? Are you going to be totally oxygen dependent, or are you going to be able to live a fairly normal life? Okay, let's dive into small cell lung cancer. So there are two types of lung cancer: small cell lung cancer and non-small cell lung cancer. Small cell lung cancer is what I'm going to talk about from now until break. It represents about 15% of lung cancer cases, okay? So it's definitely not the most common, but it is the most aggressive. And it is the lung cancer type that is almost exclusively associated with smoking. Okay, so it is very, very rare for somebody who is not a smoker to get small cell. It's not impossible, but it is very rare. Okay, so this is largely a smoking-driven cancer. It's divided into two stages. So I told you we did that TNM staging, and we do, it still applies, but there's two functional staging classes that were derived from the Veterans Affairs Administration that make this disease state a lot easier to understand. Limited stage and extensive stage. Limited stage is cancer that can fit into one radiation field. And why that's important is because if the cancer can all be encompassed in one radiation field, then it's curable. Okay, so what you need to know here is limited stage disease is curable, extensive stage disease is not. 33% of cases present with limited stage, so that's not very many. These patients are curable. We can do surgery, but we most often need to do chemotherapy and radiation combined, okay? In contrast, extensive stage disease, which makes up the majority of our cases, we cannot cure these patients, okay? So our intent of treatment is to palliate them, to relieve suffering, to decrease symptoms from the cancer, and to give them a little bit more time, but they are probably going to die from their cancer. Here, we're not using surgery because, again, there's no point in doing surgery if we can't cure the patient. We're using chemotherapy and radiation, but we might be sequencing them a little bit different, and we might only be using radiation for more palliative purposes to relieve suffering and symptoms, not so much for curing the cancer. But we do here use immunotherapy much more commonly, okay? All right, so how do we treat these limited stage small cell lung cancer patients? Surgery, again, it's possible in some, but very few. If the patient is operable and can undergo surgery, great. The surgeon will do the surgery. If they have lymph nodes involved at the time of surgery, they need more treatment, okay? So that's kind of the take-home message here. If the surgeon resects the cancer and the lymph nodes are positive for cancer, so the cancer had actually spread to the lymph nodes, you're gonna have to give them more treatment, which includes chemotherapy and radiation, okay? If there's no surgery, so the patient cannot get surgery, either the patient's not a good candidate or the surgeon says it's a little bit too advanced, it's spread to too many lymph nodes, I can't do surgery, the treatment of choice is concurrent chemotherapy and radiation, okay? So for limited stage disease, in the majority of cases, surgery is not possible, and we're doing concurrent chemotherapy and radiation. The chemotherapy here is a platinum doublet with etoposide, okay? That is something I would expect you to know. What doublet do we use in the treatment of limited stage small cell? I'm telling you exactly, it's platinum and etoposide, okay? It's not platinum and pemetrexed, it's not platinum and gemcitabine, it's platinum etoposide, okay? Because in small cell lung cancer, those cells are most sensitive to the drug etoposide and platinum. If the patient is a really poor candidate, they just have a poor performance status, lots of comorbidities, and they're not going to be able to tolerate concurrent chemotherapy and radiation, you can use those sequentially, meaning you can give the chemotherapy first and then the radiation, but the outcomes are not as good. So the patients don't have as high of a chance of cure. Okay. We do something really crazy for limited stage small cell called prophylactic cranial irradiation. This is wild. We radiate the patient's brain even though there's no sign that there's actually cancer in the brain. And the reason we do that, or potentially do that, is because small cell lung cancer has a very, very high propensity to metastasize to the brain. And the brain can become a sanctuary site where the lung cancer cells can kind of hide out. I don't know how much you guys learned about platinum agents and etoposide when you had your like pharmacology lectures, but they don't penetrate the blood-brain barrier very well, okay? So even though I have my patient that has an IV that's getting cisplatin and etoposide and it's going systemically all throughout the body, it is not going into the brain very well, okay? So all the cancer cells that are below the neck might be getting killed by the chemotherapy, but any cells that have escaped and metastasized to the brain are not. And these patients who we thought we could cure are having relapses with disease in the brain. So we can potentially radiate the brain prophylactically, right? Prophylaxis means you're doing it beforehand. So we're actually radiating the brain before the cancer gets there in an effort to decrease the likelihood that the cancer will recur in the brain, okay? The problem with this is that it's really toxic, right? It causes a lot of side effects. It causes a lot of fatigue, memory loss issues, like short-term memory, cognitive executive functioning. Patients can get some hearing changes, hair loss. So it's definitely not without risk. And some people just flat out refuse to undergo radiation when they are told, well, there's no disease in your brain, but we are hoping to prevent it from getting there. So instead, if the person does not want to undergo prophylactic cranial irradiation, we just do close brain MRIs and we try to catch the cancer at a very early stage when we just start to see the cancer growing in the brain, and then we treat it, versus when the patient comes in frank seizures because they have a massive, 1 centimeter lesion in their brain. So that's the alternative if the patient does not want to get PCI. Okay, well, I had told you that immunotherapy was largely restricted to extensive stage small cell lung cancer. But just this year, we had a clinical trial called the Adriatic study that showed that if patients with limited stage disease got their definitive chemotherapy and radiation with what chemotherapy? Platinum and etoposide, right? So if they got their chemotherapy and radiation, and then they were randomized, the trial randomized the patients to either durvalumab, which is an immunotherapy, or placebo. If they got the durvalumab, if they got the immunotherapy for 2 years, they had a significantly increased survival, right? So patients who got placebo lived 33.4 months. People who got the durvalumab for 2 years lived 55.9 months, okay? So here we see a statistically significant improvement in overall survival by giving the immunotherapy for 2 years after the completion of chemotherapy and radiation. So this is just an update change this year based off of the results of this Adriatic study. All right. Well, what do we do about the 2/3 of patients who don't qualify as limited stage, who are not curable, okay? When the patient's not curable and they have extensive stage disease, we are giving them the same chemotherapy backbone, so platinum etoposide, but this time we are not giving radiation. So whereas limited stage got the chemotherapy with concurrent radiation, the extensive stage patients are getting platinum etoposide with immunotherapy. Okay. And the reason here is that the addition of immunotherapy to the platinum and etoposide resulted in an improvement in overall survival of about 2 months. Okay. So these patients went from living 10 months from diagnosis to 12.5, 13 months with diagnosis. So we're improving the survival marginally. So that is why this is now kind of standard of care. And then after the initial combination, 4 to 6 cycles, they just get the maintenance immunotherapy. So for example, they'll get carboplatin, etoposide, and durvalumab for 4 cycles, and then they'll go on to continue durvalumab maintenance therapy until progression. If the patient with extensive stage disease has brain metastases, they might need to get the brain metastases treated up front with radiation therapy prior to the start of treatment. And again, that is because our platinum etoposide does not cross the blood-brain barrier very well and is not necessarily going to be a reliable treatment for these patients. So that's one caveat. You kind of have to start the treatment that's going to be most life-threatening for the patient. So if I have a patient that presents to the hospital with a new diagnosis of small cell lung cancer and they have significant brain mets and came in with like ataxia and seizures or anything like that, then we might need to start the radiation treatment to the brain while we're planning the chemotherapy. All right, well, what do we do when these patients progress? Because they will progress, okay? That's the problem with extensive stage small cell, is that it does respond to treatment, but the responses are not durable. And almost everybody relapses, and they typically relapse pretty quickly. The theme here is that if the patient recurs and it's been more than 6 months from the time that they got the initial platinum etoposide, you can reintroduce platinum etoposide, okay? So if the initial chemotherapy of platinum etoposide worked and the cancer was controlled on the maintenance immunotherapy for more than 6 months, go ahead and add the platinum etoposide back in and give them another 4 cycles. But if the cancer recurred and it had only been like 1 month or 3 months or anything like that, it's probably resistant to the carboplatin and the etoposide. So you're going to want to use a different agent, okay? And these are just some of the drugs that are available that are effective in small cell. And then, lurbinectedin, and I think that's unique, a drug I don't know that you guys have learned about. I wouldn't test you on that because I don't think you guys have had that one. Topotecan, though, I do believe you guys had topoisomerase inhibitors. And then tarlatamab is that bispecific T-cell engager therapy that I mentioned on the first slide, which was kind of a recent update within the last 2 years. All right, I'm going to give you guys a break before we dive into non-small cell lung cancer. Let's go about 5 minutes because there is a lot of material to cover, and I want to make sure you guys have time for questions at the end.
Well, I'm about to start, so when I'm done, I'm gonna send it to me, you, and Fire.
Let's do it. Still studying, is it? Yeah. Yeah, man, I started yesterday. I started like studying yesterday, that's right.
You're rich, so. Yeah, money.
Hey, you're looking at first lecture, is it like
I know you have.
easy to know what's the get one? That's not my role. There's no. I think one of the notes and the objectives, whatever, they're like, I would want to. Wow.
What, you have no choice, right? You have no choice.
Yeah, I think always are, so that
Yeah.
upcoming exam in this case.
But you have.
I just want the new, like. I want the next module. No, I enjoyed it. But.
It was really.
Like literally great of the, they're like, but I think they're gonna focus.
Yeah, I remember I asked her about it, she was like, "Tuesday, I take it." So I mean. About it yesterday.
All right, guys, let's get started so you guys can have some time at the end to ask questions. For the next section, we're gonna dive into non-small cell lung cancer, okay? Just to compare and contrast between small cell and non-small cell. First, I do just want to emphasize that with small cell, we talked about the two stages, limited stage and extensive stage. With non-small cell, we're going to be going back to that TNM staging with the stage 1, 2, 3, 4 that we talked about, because how we treat the patients kind of aligns with the different staging. And this is by far the most common type of lung cancer, okay? And I mentioned that with small cell, most of our patients with small cell have a smoking history and usually a pretty heavy smoking history. With non-small cell, this is where I get patients that are never smokers. So I can get a 20-year-old, I can get a 25-year-old who's never smoked a cigarette a day in their life, present with stage 4 lung cancer, okay? And I think it's a common misconception still amongst a lot of people that you have to be a smoker in order to get lung cancer. And that's just not true. The only prerequisite is that you have lungs, which we all do. And the fastest growing cohort of patients with lung cancer are female never smokers. So it is certainly something that's an active area of research. Is it due to air pollution? Is there some interaction with hormones? It's a little bit unknown. It's really hard to do the epidemiologic studies in order to identify what the causative agent is. And in the majority of patients, especially my non-smokers, we have no idea why the patient developed lung cancer, okay? So common question from patients, why did I get this cancer? We don't often know, okay? And the answer a lot of times is just mutations in a bad area, like a bad luck mutation that developed in the lung cells that led to the growth of cancer. Okay, when I was going through pharmacy school back in 2006, we kind of thought of lung cancer, especially non-small cell lung cancer, as like one disease. We kind of refined this thinking into a histology-based subtyping. So remember when I talked about the histology slide and needing to name the cancer, I said you had to know whether something was squamous or adenocarcinoma or non-squamous. That's still true. And we thought that, okay, that's a more sophisticated way to name the cancer. But now we know that there are multiple subsets of non-small cell lung cancer that are driven by different mutations. So there's lots of different ways that people develop cancer due to various mutations that are picked up in the cells of the lungs that will affect our treatment strategies. Again, I'm not going into all of these, but I want you to have an appreciation of how heterogeneous this disease state is, okay? People think cancer is one subset of pharmacy. I think once you get in it and you learn a little bit more about it, you realize that breast cancer is entirely different than lung cancer, which is entirely different than leukemia. And then even within lung cancer, all of the different subtypes are completely different from one another and have different characteristics, growth patterns, and responsiveness to treatment. Okay, so to review, when we are formulating a treatment plan, we're going to need the tumor characteristics and the patient characteristics, okay? This is an important slide. I would probably star this one, not because I'm going to directly test you on this, but if you don't understand this slide, you're going to have a hard time with the test questions, okay? So study this slide just so you have an understanding of how you're going about thinking of formulating a treatment plan. So first of all, stage of disease. We talked about this, right? We know that the earlier limited stage, like the stages 1 and 2, where the cancer is just the solitary tumor without lymph node involvement, that's going to be potentially curable. Versus our diseases that have now spread to the lymph nodes and then finally to like the liver or adrenals or a distant part of the body, those are not going to be curable, okay? We know that we need the histology, which you get from the pathologist. What cell type of origin is this? The lung has different cells within. There's the adenocarcinoma cells that typically are in the periphery of the lung, and then the squamous epithelium that's typically lining the airways. So where did this cancer arise? How did it develop? Then there's the PD-L1 expression, okay? This is an important biomarker. This is a biomarker that you need to understand because it is important in coming up with treatment approaches. PD-L1 is expressed as the tumor proportion score, which is a percentage from 0 to 100%, okay? So your PD-L1 expression is going to be somewhere between 0 and 100%. If it is less than 1%, it's considered negative. If it's greater than 50% or equal to 50%, it's considered high. And if it's in between, it's considered low. So there are people are either PD-L1 negative, PD-L1 low, or PD-L1 high. The other piece of information that you have to know is whether the patient has a particular driver mutation. So if you recall back on this slide, the far pie graph with all of the different mutation subsets, you need to know if one of those is present, okay? And in particular, for what I would test you guys on, we said we're only really going to talk about 2, EGFR and ALK. You definitely need to know whether the patient has an EGFR or an ALK mutation, okay? And why that's important is because if the patient has an EGFR or ALK mutation, I don't care what their PD-L1 expression is, okay? So the EGFR or ALK mutation trumps the PD-L1 expression, okay? You can't rely on the PD-L1 expression. It becomes an unreliable biomarker when the patient has an EGFR or ALK, okay? So if you don't have that information, like you don't know what the EGFR or ALK mutation status is, or the PD-L1 expression, or the histology, you're not gonna be able to formulate a treatment plan. You're just gonna be guessing because you need to have that information. And then we always need to consider what does our patient want, okay? What does our patient want and what can our patient tolerate, right? Especially when we're not trying to cure the cancer or we can't cure the cancer, we don't want to make the patient sicker or worse. So have you guys been introduced to the ECOG performance status? Eastern Cooperative Oncology Group? Okay. The performance status is a scale of 0 to 5. 0 is fully functional, no limitations. You can go out and jog a lap around this building right now if you want. You have no limitations in work. Your functional status is completely uninhibited. 5 is dead. So anything from 1 to 4 is going to be a variation of that, where 1 has like some limitations with like exercise. 2 has more limitations with like, okay, they can't really do work, but they can do all their ADLs, like they're completely independent. They can brush their teeth, they can get themselves showered, they can get themselves dressed. 3, when we get into like 3, the patient is not capable of doing their ADLs by themselves. They need like a caretaker. And then 4 is like completely bedbound. So you can look that up if you're interested. You just Google the Eastern Cooperative Oncology Group performance status. But what you really need to know is that the scale 0 correlates with fully functional, 5 is dead, 1 to 4 is in between. We generally offer treatment to patients who have an ECOG performance status of 0, 1, and 2. We do not usually offer treatment to people who have an ECOG performance status of 3 or 4. We recommend best supportive care or hospice because those patients are unlikely to tolerate our treatments very well. And they could actually be more sick from treatment. And then, of course, what is the patient's goals, right? Maybe the patient doesn't want to undergo treatment, and that's something we have to respect, even though it might not be what we would choose as an individual. It's not about what we would choose as an individual, it's what the patient wants. Okay. Theme here was stage 1. These are our very isolated tumors with no lymph node involvement. We can cure these patients, okay? So our goals of therapy are to cure. And because these are very localized cancers, we can surgically resect them. So our go-to is going to be surgery. We also want to make sure that the surgeon goes in and looks at the lymph nodes. So when they go in and they do the surgery, they also do what's called a lymph node dissection, and they take out the lymph nodes in the surrounding area and in the mediastinum, and they send those off to the path lab. And the pathologist is going to make sure there's no signs of cancer in there, okay? Because just because it didn't look like the lymph nodes were involved on the imaging and the CT, they might be involved when they actually look at the cuts under the microscope, okay? So that's what we mean by mediastinal lymph node dissection. We're just being doubly sure that the cancer was as localized as we thought it was. The goal is to get negative margins, okay? That means that there is no cancer in any of the cells around where the cut was, okay? If the sample's sent off to the path lab and there's cancer cells abutting the line of the surgery, there's probably cancer cells that were left in the patient's body, and that is going to cause recurrence, and the patient's not going to have that benefit from surgery, okay? So when we say the goal is an R0 resection, that means the goal is to get all of the cancer, okay? That's why if the surgeon can't do that, he or she needs to tell that to the team and say, I don't think I can surgically resect this with R0 resection. Then we wouldn't recommend the patient for surgery, okay? If the patient either can't undergo surgery or refuses surgery, we can do definitive radiation. The radiation oncologist comes in and they give a high dose of radiation to the tumor area and a little bit to the surrounding tissues, and they kind of zap the cancer with radiation, okay? Stage 1 tumors do not need any more treatment. That's it, they're done. High chance of cure with just one of those 2 treatment strategies, okay? We don't need to do anything else. However, some patients whose cancers are a little bit bigger, they have a higher risk of recurrence, and we need to give a little bit more, okay? So for these patients, we will maybe offer adjuvant chemotherapy. What does the word adjuvant mean? It means after surgery, okay? So we will offer them additional chemotherapy after surgery to mop up any cancer cells that may have been left behind. This is going to be an important recurring theme. If the patient has an EGFR mutation, we will then also offer them the drug osimertinib. Okay, and I'll talk about osimertinib in a couple slides. But if they're EGFR positive, I want you to be able to associate EGFR positivity with osimertinib. Similarly, I want you to be able to associate ALK positive with alectinib, because these patients can be offered adjuvant alectinib for 2 years instead of chemotherapy. And if the patient is PD-L1 positive, so if their PD-L1 score is greater than 1%, they can potentially get immunotherapy. But you don't do multiple of those, okay? So let me be very clear. You get your surgery, then you potentially get your chemotherapy, and then you get either osimertinib if you're EGFR positive, or immunotherapy if you're PD-L1 positive, or alectinib if you're ALK positive, but you're not EGFR and ALK, and we don't care what your PD-L1 score is if you're EGFR or ALK, right? So that's kind of the differentiation that I want you to be able to associate. All right, now we have stage 2 disease, okay? Things are a little bit more advanced, okay? If the patient has no lymph nodes, so N0, remember N stands for lymph nodes. If there's no lymph nodes involved, we can do the same thing we did with stage 1, okay? If the patient has lymph nodes involved, so there was disease in some of the lymph nodes, we can do surgery again, but which we could do if the patient's a good surgical candidate and wants surgery, but we're gonna have to do something else on the tail end, okay? Because we're gonna have to increase the aggressiveness of our treatment because this cancer's got a higher chance of recurrence now. If the patient can't get surgery and they have lymph nodes involved, we are now giving definitive chemotherapy and radiation together. We cannot just give the radiation, okay? Chemotherapy and radiation together work synergistically. The chemotherapy creates damage to the DNA, and then the radiation does that final kill of the cells, okay? So if the patient has lymph nodes involved and we can't do surgery, or we're not going to do surgery, we now need to give them definitive chemotherapy and radiation together, not sequentially, like at the same time. So the patient comes in, they get chemotherapy either once a week or once every 21 days, and they get radiation treatment Monday through Friday for 6 weeks in a row. Okay, as I mentioned, if our patient gets the surgery, they need something else, right? Because they're now stage 2. Their chance of recurrence is higher. And that is going to be, again, this is, again, similar theme. If they're EGFR positive, right, they're going to get the chemotherapy, and then they're going to get 3 years of adjuvant osimertinib, EGFR osimertinib. If they are PD-L1 positive, they can get immunotherapy, atezolizumab or pembrolizumab. And then if they're ALK positive, you can omit the chemotherapy and give the 2 years of adjuvant alectinib. So I'm not going to get into the weeds as to like, well, who can skip the chemotherapy and who goes on. I just want you to be able to associate which populations might be candidates for different therapies, okay? So EGFR positive, potentially osimertinib, ALK positive, potentially alectinib, PD-L1 positive, potentially adjuvant atezolizumab or pembrolizumab. Stage 3 is super, super, super complicated. It's kind of like multiple pathways. There's so many different combinations of things that we can do. To simplify it for you, you need to understand that we need multimodality treatment, okay? We can still cure these patients, but these patients need at least 2 of surgery, radiation, chemotherapy, targeted therapy, immunotherapy. Like, they need multiple tools in our toolbox because their cancer is at highest risk for recurrence with any one modality alone, okay? When we're determining if somebody is resectable or unresectable, anybody whose lymph nodes have spread to that contralateral side, they are unresectable. Patients who have mediastinal lymph node involvement may or may not be resectable depending on the case. And these are often evaluated in like what we call our tumor board. So it's even complicated for the medical oncologists and surgeons to determine. So I wouldn't necessarily, again, I'm not testing you on any of the staging and how that relates, but we're seeing common themes here, okay? What's another common theme? If they're EGFR positive, we're giving them osimertinib for 3 years. If they're ALK positive, we're potentially giving them alectinib. And if they are PD-L1 positive, we are potentially giving them immunotherapy. One thing that's different is that final fifth little like tick, the neoadjuvant. That is one thing I want you to kind of differentiate here. That's a little bit more common. We're now introducing neoadjuvant therapy. You didn't hear me say the word neoadjuvant until we got to this slide, right? What do you think neoadjuvant means? Before surgery, okay? So here we are potentially giving treatment before surgery because perhaps we want to be able to shrink the tumor down to make the surgery a little bit easier, okay? We also can kind of give, it's like a preview. It's kind of like testing the waters, right? If we give the patient neoadjuvant treatment before surgery, we kind of get an idea of how chemo responsive or immunotherapy responsive the tumor is. If the patient has a really good response at the time of surgery. So we give the neoadjuvant treatment and then the surgeon takes them to the OR and there's no signs of cancer left. That means that patient had a complete response to neoadjuvant treatment. That's fantastic. That actually predicts a longer survival. But if the surgeon takes the patient to the OR and the tumor is the same exact size it was 2 months ago when we were starting treatment, that's a really poor prognostic factor because that basically means that that tumor did not respond at all to the treatment that we gave it. And it's probably not going to respond to really much of anything that we give the patient. So all that to say that that gives us some valuable information, and we can do that particularly with our stage 3 patients where we give them treatment up front, maybe like 3 or 4 cycles of treatment, and then we take them to surgery, and then we continue the immunotherapy on the back end after the surgery. So that's our adjuvant immune checkpoint inhibitor. Okay, this is just further going into that concept of neoadjuvant therapy, okay? So this is like what we do, like perioperative, peri meaning around. So this is treatment before the surgery and then treatment after the surgery. So these are some of the patients that we would kind of recommend for this treatment approach. Patients whose tumors are greater than 4 centimeters or they have lymph node involvement, and then they don't have a contraindication to immunotherapy. That information in that blue box that's in red is going to be a really important concept to understand and something that I would expect you to potentially be tested on and be able to answer correctly, okay? Immunotherapy. What does immunotherapy do? Immunotherapy is using the patient's own immune system, so stimulating the immune system to attack the cancer. Did you guys have pharmacotherapy of like autoimmune diseases yet? Okay, so you have the concept that like our immune system exists in a very delicate balance every single day, right? If our immune system is too active, we have autoimmune disease. Our immune system is inappropriately attacking things that are self and should be left alone. If our immune system is too lazy or too kind of weak, we are at risk for infection and cancer because our immune system is supposed to be running surveillance on a daily basis. I mean, I have cancer cells that are popping up in my body every day, right? But my immune system is identifying them, taking care of them, and they don't become a tumor, okay? If our immune system is not responding in the robust way that we want it to, the cancer is able to grow and kind of persist. So we can harness the immune system to try to stimulate the immune system to attack the cancer better, okay? But who might not be a good candidate for that strategy? Anybody who has an autoimmune disease, right? Because if we give them something that's going to stimulate their immune system, that's going to cause that autoimmune disease to go haywire, okay? So a contraindication to giving immunotherapy or immune checkpoint inhibitors is somebody with a concurrent autoimmune disease or someone who's on immunosuppressive agents, right? It does me no good to give something that's going to stimulate the immune system if the patient's on a drug that's supposed to suppress the immune system. I'm just wasting time and money. Yeah.
What if a person is not following HIV treatment? Would that put them on increased risk of developing cancer?
Yes, absolutely. Yep. So we actually see a lot of cancers in HIV patients and advanced stage HIV patients because their immune system is non-functional and it's not running surveillance. So lots of HIV positive patients with poor HIV heart therapy like compliance and poor control can get diseases like Kaposi sarcoma, Burkitt's lymphoma. Like there's a whole spectrum of AIDS associated malignancies that we see because their immune system's not functional. But having HIV is not a contraindication to giving immune checkpoint inhibitors, okay? Because if the patient's on heart therapy and they're compliant, then we can give them immunotherapy. The other thing that's a relative contraindication to getting immunotherapy is having an EGFR or ALK mutation. Okay, so I kind of told you that like that PD-L1 biomarker sort of falls apart if the patient has an EGFR and ALK. Giving them immunotherapy is a relative contraindication because these patient groups don't tend to respond to immunotherapy. Okay. These are just an example. It's just a table for you to see what types of chemotherapy we give here and what combinations, and then what's the schedule, like how many days, how many cycles, et cetera. One important theme here that I want to point out is that when patients have squamous disease, we do not use pemetrexed. Okay, so if you highlight anything on this slide, it's that pemetrexed is only used in patients with non-squamous histology. Okay, gemcitabine can be used in either histology, but preferentially our squamous histology. Paclitaxel can be used in any histology, but the one take home that I really want to emphasize here is that pemetrexed is only used in our non-squamous. Okay, so if I gave you a test question, I said this patient has stage 3 squamous non-small cell lung cancer, and one of the options was to give the patient cisplatin pemetrexed, that would immediately be wrong. Okay, what about if we are giving radiation? So remember I said that sometimes we can't surgically resect the tumor and we have to give radiation in combination with chemotherapy. There are certain regimens that we tend to give specifically in combination with radiation, and that those are shown on this slide, okay? So the take home here is just that, we aren't seeing the whole breadth of options as we did on the previous slide. We have more limited scope here with pemetrexed, etoposide, paclitaxel. Again, we are not giving pemetrexed to patients with squamous histology, okay? So if the question was a little bit different and it was asking about which regimen is most appropriate for a patient with stage 3 unresectable squamous non-small cell lung cancer about to undergo chemotherapy and radiation, you shouldn't be picking pemetrexed. In that box on the bottom, when our patients have unresectable disease and we give them concurrent chemoradiation, these patients are recommended to get a year of durvalumab therapy because this has been shown to increase overall survival. So patients who get definitive chemotherapy and radiation because they were unresectable and not able to undergo surgery, if they get their definitive chemoradiation, they respond well, they don't have any disease progression, they should be offered a year of immunotherapy with durvalumab unless they have a contraindication to immunotherapy. And what are your contraindications to immunotherapy? Good. Autoimmune disease, on immunosuppressive agents, or EGFR, okay? All right. Let's dive into stage 4, okay? Unfortunately, these are our patients where we are no longer able to go for a cure, okay? So for stage 1, 2, and 3, our goal was to try to cure them of their cancer, but these patients, unfortunately, are non-curable. And so our goals of therapy are to palliate symptoms, to improve their quality of life, and prolong the quantity of life. Some common sites that non-small cell lung cancer likes to metastasize to are the bones, the brain, the liver, and the adrenal glands, okay? So bone metastases put our patients at risk for a pathological fracture where the cancer goes into the bone and it stimulates the osteoclast activity, which chews up all the bone matrix and can cause a weakening of the bone, which puts the patient at risk for fractures. I have had patients, especially young, never smoking patients whose diagnosis of cancer came because they randomly broke their leg, like without any like precipitating sports related injury or car accident. And it was because they had an unknown to them at the time, bone metastases that had chewed up the structure of the bone and had created a pathologic fracture. Essentially, the bone broke because it had been weakened from the cancer. We talked in my lecture on Wednesday about different treatments for like hypercalcemia of malignancy and talked about like spinal cord compression and superior vena cava. This is a situation, these stage 4 lung cancer patients, where you might start to see some of those oncologic emergencies, right? So you can imagine, remember when I talked about hypercalcemia malignancy, and I said when the bone, like 80% of patients with hypercalcemia malignancy have it because the bone, cancer is going in and chewing up the bone and releasing all that calcium. So this is all related, right? There's very commonly, these patients can come in and have hypercalcemia that needs to be urgently treated. Brain metastases might need more urgent treatment as well because the patient might be symptomatic and we need to relieve the pressure, right? Your brain is encompassed in your skull and there's not a lot of real estate for swelling, right? The brain can't accommodate a lot of changes, and any increased intracranial pressure is going to cause all kinds of problems like severe headaches, nausea, vomiting, seizures, etc. Most of our chemotherapy has poor penetration into the central nervous system, right? When we were talking about small cell, that's why I introduced the concept of prophylactic cranial irradiation, because I told you that carboplatin and etoposide don't cross the blood-brain barrier very well. So that's true of most chemotherapy agents. Immunotherapy might be able to produce responses in the brain. Now, it's not that those big, bulky monoclonal antibodies are crossing the blood-brain barrier, because we know those big, bulky monoclonal antibodies don't cross. But because immunotherapy stimulates T cells of the immune system, T cells can cross the blood-brain barrier. So we can activate the T cells kind of below the neck, and those activated T cells can cross the blood-brain barrier. So you can see responses in the brain to immunotherapy. And then a lot of our targeted therapy pills, which the two that I've introduced you all to is osimertinib and alectinib, those have fantastic CNS penetration. So those two drugs can get into the brain. And so if patients have EGFR mutations or ALK mutations, they can at least be a little bit more, they have a little bit more we have more confidence that their brain metastases might be adequately treated. I mentioned performance status and that we really only offer therapy to people who have a performance status of 0, 1, and 2. If the performance status is 3 or 4, we most likely will recommend that they just get symptom-driven management and best supportive care or a hospice. Okay. And again, that's because our treatments are going to be associated with side effects. You guys learned about topoisomerases and all the toxicities. You learned about platinum agents and all the toxicities, right? Those patients who have a really poor performance status and are really, in bed most of the day, they're unlikely to really benefit, and any side effects that they have are going to be poorly tolerated. And we always want to refer our patients to palliative care, okay? There's a misconception amongst most people in society that palliative care equals hospice. Palliative care does not equal hospice, okay? Hospice is really more end of life, no more active treatment. We don't have anything else that's going to offer you benefit. Palliative care is just symptom-driven treatment, okay? So palliative care should start the minute someone is diagnosed with metastatic lung cancer, even if that patient goes on and lives 5 years, okay? Because it's focused on symptoms and it's focused on alleviating suffering, okay? And there's been studies that have actually shown that if you get a patient to buy into palliative care and get in with a palliative care provider early on, they have better survival just from getting into palliative care, not regardless of what treatment we give them, but because someone is there and acutely attuned to their symptoms and helping them to feel better on a daily basis, it improves survival. So can't emphasize the benefit of palliative care enough. Okay. The approach to treating or coming up with a treatment plan for our stage 4 patients. We mentioned that we have to have that biopsy because we have to understand the histology and we have to be able to get information about the PD-L1 expression and the molecular drivers, okay? So we first need to get the histology. Is it non-squamous or squamous, okay? If it's non-squamous, everybody needs full molecular testing. If it's squamous, we should probably get them molecular testing, but especially if they're a light or never smoker, okay? Don't think I made this clear, but I will do so now. We'd mentioned that non-smokers and smokers can get non-small cell lung cancer. Non-smokers who get non-small cell lung cancer tend to get non-squamous lung cancer. Smokers who get non-small cell lung cancer tend to get squamous, although they can get both. So almost always never smokers have non-squamous histology. That's why we're really looking for those molecular drivers in anybody with non-squamous because they're more likely to harbor it, okay? That's kind of getting a little bit in the weeds. In general, it's not wrong to know that everybody with stage 4 non-small cell should be getting next generation sequencing or molecular testing. Everybody with non-small cell need to know PD-L1 expression, right? So negative, low, or high. We need to know their PD-L1 expression. And then we need to know their molecular drivers, okay? I wouldn't test you on this, okay? This is just for me to be complete and not be misleading. These are all the different therapies that we give based off of the different targets. But what you do need to know is that first bullet. Our EGFR and our ALK positive patients, they start targeted therapy first, okay? So if you are EGFR positive or ALK positive, I don't care what your PD-L1 expression is. I don't really care what your histology is. If you have an EGFR mutation or an ALK mutation, we're going to start you on that targeted therapy, okay? If the patient does not have a molecular driver, so if they don't have EGFR or ALK, now I need to know what the PD-L1 is, okay? Because I forget about the PD-L1 if they're EGFR or ALK positive, okay? We say, all right, we did the testing. You do not have an EGFR or ALK mutation. Now I look at the PD-L1 and I say, what's the PD-L1? If the PD-L1 is high, greater than 50%, the take-home message here is that these patients have a high enough chance of responding to immunotherapy alone that they are potentially candidates for immunotherapy alone. That's why it's bolded, okay? These PD-L1 high patients can potentially get a good response to just immunotherapy. In contrast, our patients who are PD-L1 low or negative, they're not going to respond to single agent immunotherapy alone. They need to get chemotherapy plus immunotherapy, okay? So that's kind of the take-home message here, okay? You don't need to worry so much about everything that's on this slide, but the take-home is that PD-L1 high can get immunotherapy alone, PD-L1 less than 50% or low, they need chemotherapy plus immunotherapy, okay? And you then have to choose the chemotherapy partner based on the histology. So remember from the previous slide, I said that our non-squamous patients should get pemetrexed. It's never appropriate to give our squamous patients pemetrexed, okay? So the histology matching there comes in with the chemotherapy partner. If the patient has non-squamous, think pemetrexed. Squamous, don't give them pemetrexed. Okay, these are just, again, for your, like a resource reference for you. It wouldn't necessarily test you on the doses or anything like that, okay? But this is just an example of some of the regimens. Single agent immunotherapy, immunotherapy plus chemotherapy, and then there is a combination immunotherapy option for people who want a chemotherapy free. I'm not gonna go into that. All right. Let's talk briefly about these targetable mutations that I've been referring to. So the first mutation I want to talk about is EGFR. Did you guys learn about epidermal growth factor receptors? Okay, so maybe this will be review. I don't know. It's found in around 20 to 30% of patients with non-small cell lung cancer globally. In Asian countries, it's more than 50%. So more than 50% of people who present with lung cancer have an EGFR mutation. And in particular, Asian never smoking females, okay? And when I say Asian, I don't mean like China, Japan, I mean the Asian continent, including India and countries in that part of the world. Females tend to have a higher percentage than males for EGFR mutations. And these are almost always never smokers and almost always adenocarcinoma or non-squamous. EGFR is a gene and a protein, stands for epidermal growth factor receptor, and the pertinent part of the gene that gets mutations that lead to development of cancer are what are considered the tyrosine kinase domain, okay? So these mutations occur in exons 18 to 21, and the ones that are most relevant are two particular mutations, exon 19 deletions and a point mutation in exon 21 called L858R. Did you guys learn about that or no? Okay, all right. The specific EGFR mutation is important because our patients that have those exon 19 deletions and that L858R in exon 21, those are our classic EGFR mutations, okay? That is kind of the extent with which I would want you to know anything more about the EGFR gene. But what essentially happens is this protein gets switched on constitutively. So normally, EGFR only signals to the cell to divide when there's a ligand bound to it, okay? That's kind of like the on-off switch, right? When we want it to signal, the ligand's bound to the receptor sends a signal to the nucleus of the cell divides. When the mutation occurs, it doesn't matter whether there's ligand present or not, that protein is constitutively active and it is constantly signaling to the nucleus of the cell to divide. That's where we have the unchecked cell growth, which is a hallmark of cancer, okay? So that is how these cancers they're addicted to this pathway, okay? So the best way to treat these cancers is to develop a drug that binds into that tyrosine kinase domain, that pocket, and stops that signaling, shuts that signaling down, kind of switches that off, okay? And that's exactly what we do when we talk about the drug therapies, okay? So these drugs, there's 5 of them on the market. They are all different iterations of an EGFR inhibitor, okay? The first generation agents are gefitinib and erlotinib. They had limitations in that they didn't really cross the blood-brain barrier. Okay, that's going to be a limitation for any drug in lung cancer because lung cancer loves to metastasize to the brain. So if the drug can't go across the blood-brain barrier, that drug is going to have very limited duration because the patients are typically going to progress with brain metastases. So erlotinib and gefitinib are not really used as much anymore because they don't have CNS penetration. Afatinib and dacomitinib are second generation agents. They're what we call pan-HER inhibitors. I don't know if you guys learned in molecular biology that EGFR is kind of a member of the HER superfamily of proteins. So afatinib and dacomitinib can actually inhibit multiple of the HER, right? HER1 is the same thing as EGFR. So EGFR is HER1, and there's a superfamily of HER2, HER3, HER4, et cetera. They're pan-HER inhibitors, which was thought to be maybe beneficial, that they would be more effective. That didn't really pan out that way per se. They are more toxic for sure, okay? One benefit that they have is that they tend to work with some of the non-classic EGFR mutations. That's why there's the red box up there, is that afatinib does have efficacy for some of these EGFR mutations that are not exon 19 deletions or L858R. You don't really need to worry about any of those. The one you need to worry about is osimertinib, because that's the one I've been talking about all class that we typically use in practice now. It's our third generation EGFR TKI, and why we love it so much is it crosses the blood-brain barrier, okay? So it crosses the blood-brain barrier really well, and because of that, it's been shown to increase survival, okay? So this was a head-to-head trial between gefitinib or erlotinib versus osimertinib. It was a global trial worldwide, and the patients who were randomized to the osimertinib had not only a longer progression-free survival, so a longer time on treatment before the cancer progressed, but they also lived longer, okay? So as a result of this clinical trial, which did a head-to-head comparison between what used to be the standard of care to what was new to the market, osimertinib took the crown for being the most effective EGFR inhibitor. So that is why this drug is the preferred first-line therapy for EGFR mutations. Okay, this is an important slide because we're pharmacists and we should understand the toxicities of the drugs that we use, okay? So as a class, EGFR tyrosine kinase inhibitors are associated with diarrhea and rash. That is something I absolutely would expect you to understand and be tested on, okay? So the two most common side effects are diarrhea and rash. For diarrhea, we can use OTC anti-diarrhea agents like Imodium, and we can use things like Lamodal, which is prescription, if the diarrhea is not relieved with Imodium. If the patient's been using anti-diarrheal agents and they're still having multiple stools a day and at risk for becoming dehydrated, we can dose reduce the EGFR inhibitor. So for osimertinib, which is typically started at 80 milligrams per day, we can reduce the dose to 40. The rash can have multiple manifestations. In general, the patient's skin is just a lot more dry and red and itchy. For those types of things, we can use moisturizing lotions and topical corticosteroids. The rash can also be acneiform. So an acneiform rash is acne-like. It has little pustules and papules. It's not acne though, right? Because what's acne? Acne is defined by bacteria and a local inflammatory reaction to like clogged pores and bacteria there. There's no bacteria involved here and the pores are not clogged. It's because epidermal growth factor receptor is a normal protein that we all have in the epidermis of our skin, okay? So we would love for these drugs to just inhibit the mutant EGFR in the lung, but we don't have that level of sophistication with our drug therapy yet. So unfortunately, these drugs that inhibit the EGFR that's mutant in the lung to treat the lung cancer also inhibit the EGFR that's in the epidermis of our skin. So that's why we get the skin toxicities from this drug class. For the pustular presentation of the rash, we can use topical clindamycin gel or lotion. And you're going to say to yourself, wait a minute, you just told me that this is not like acne. Why am I using topical clindamycin lotion or gel? The reason is because clindamycin and doxycycline have anti-inflammatory properties as well, okay? So when we use topical clindamycin, we're not using it for its antibacterial properties, we're using it for its anti-inflammatory properties. When the rash is really severe and it covers a large part of the surface area of the body and we can't just slather topical products on the patient all the time, we can use doxycycline. It's very effective in reducing the rash. And in very severe cases, we have the patient hold the drug and we do pulse dose steroids because steroids are just generally anti-inflammatory. Occasionally, patients can get mouth sores, and then another side effect that kind of goes along with EGFR inhibition is paronychia. Paronychia is irritation, swelling around the nail beds. So that can occur on the fingers and the toes. And you think, okay, well, that's probably not that painful. It's incredibly painful. And depending on what your patient's like job and livelihood, it can really interfere with their quality of life. So I have people who are musicians who can no longer play the guitar. And I have people who are, in IT and maybe typing all day. And you can imagine that if you have a lot of pain and discomfort on your fingertips, every time you're typing on the keyboard, you're going to be like reminded of just how bad that is. So it can be really painful for patients, and it can be a really troublesome side effect. All right, let's switch gears and go to our ALK positive. This is a slightly different genetic change that occurs, okay? Did you guys learn about gene rearrangements? Okay, so this is a gene rearrangement. This is not a mutation, okay? This is where, it's a mutation, but it's not like a point mutation like EGFR is, or deleted DNA base pairs like EGFR can be. This is a chromosomal swap, okay? So what happens is there is an rearrangement or a translocation within the chromosome to create a fusion protein, but the same end problem occurs as with EGFR. We have a constitutively active protein, okay? So mutations that led to a constitutively active EGFR protein, this chromosomal rearrangement leads to a constitutively active ALK protein, and they both create unchecked cell growth because they're signaling to the cell to continuously divide. This is a much less common mutation. This only occurs in around 3 to 5% of patients with non-small cell lung cancer, and it's very common in never smokers and those with adenocarcinoma. These are my youngest patients. Not to say that you can't have ALK rearrangements in your 60s and 70s, you absolutely can. I typically don't see EGFR mutations much younger than 30, but I have several patients in their 20s with ALK rearrangement. So if you've ever known somebody who has stage 4 lung cancer, good chance, and they're very young, good chances that it's ALK positive. There are, again, 5 drugs on the market, various generations, first, second, and third generation agents. We don't use crizotinib anymore because it doesn't cross the blood-brain barrier, right? So common theme. The drug really doesn't have a lot of longevity if it doesn't cross the blood-brain barrier. Ceritinib, alectinib, and brigatinib are all second generation agents. We don't really use ceritinib anymore because it caused a lot of GI toxicity. It was not very tolerable. Alectinib and brigatinib and lorlatinib all have really good CNS penetration, and those are going to be the agents that we typically use the most, okay? So when we are talking about metastatic ALK positive patients, we have 3 options. And there's no head-to-head trial to tell you which one of these 3 is superior, okay? So all 3 of these are an option when we're talking about metastatic patients. Which one of these drugs is the only one that we ever give in the adjuvant setting, though? I think this girl in the front, you had it. Alectinib, right? Correct, right? So alectinib was the only one that I introduced in the early stage because alectinib is the only one that's been shown to be beneficial for patients who've had surgical resection to decrease the risk of recurrence. But when we're talking about metastatic patients where we're no longer going for cure, any one of these 3 is going to be an option. You do see, though, that the lorlatinib data does look a bit better as far as the intracranial response. So in practice, when our patients have brain metastases, we typically will recommend lorlatinib. All right, what about toxicity and management for this drug class? Well, unlike EGFR, where almost all of the EGFR inhibitors cause diarrhea and rash, it's a little bit harder to define class side effects here, but what they most all have in common is liver toxicity, so elevation in AST, ALT, and potentially T-bili. A side effect called ILD, interstitial lung disease, or pneumonitis, where the drug causes inflammation in the lungs, a slowed heart rate or bradycardia, and peripheral edema, where my patients say that they get fluid retention in the lower extremities and occasionally in the peripherally, the upper extremities as well. So for these drugs, you have to monitor liver function tests, okay? As a pharmacist, monitoring is one of the main things that we do as part of the treatment team. We make sure that these drugs are safe for patients. So we have to monitor liver function tests. I put the intervals up there. I wouldn't expect you to know the intervals. I just want you to be able to associate that we need to monitor for liver toxicity with these drug class. Lorlatinib is very unique in that it causes hyperlipidemia in up to 85 to 90% of patients that get this drug. So lorlatinib is unique in that we have to monitor a lipid panel. We typically get one at baseline, and I will see patients have their LDL triple with starting this drug within 2 weeks, okay? This does not lead to, or the data has not shown that this increases the risk of cardiovascular events such as heart attacks and strokes. But we still want to make sure we treat the LDL, the elevated LDL. So we do need to start these patients very often on statins. Drug interactions can also be a concern with this drug class, with the exception of alectinib. Alectinib doesn't tend to have very many drug interactions. All right, in the last 15 minutes, we're going to talk about immunotherapy and immune checkpoint inhibitors. I'm glad that I saw some heads nodding when you guys said that you had an introduction to autoimmune disease. So some of this stuff hopefully should be a little bit of a review. Okay, immunotherapy is in a very unique class. It is not chemotherapy. Chemotherapy non-specifically kills rapidly dividing cells, okay? Targeted therapy is biomarker-driven therapy like the osimertinib and alectinib that we talked about. Immunotherapy is its own classification. It works with the patient's immune system to reinvigorate the immune response to the cancer. The immune system, for good reason, has various checkpoints to make sure that it stays in line and it's not inappropriately responding to self-antigens or inappropriately ignoring foreign material, okay? So there's multiple checkpoints to kind of make sure that the immune system is kind of staying on the straight and narrow. Tumors can sort of override or evade the immune system by interfering with some of these checkpoints, okay? So they can do things that can be kind of sneaky to kind of tone down the immune response to them. They essentially kind of trick the immune system into thinking there's no big deal. Hey, I should be allowed to be here. And they do that in ways that will allow the cancer to continue to grow and progress, okay? So drugs that are checkpoint inhibitors are designed to restore this kind of like tampered down or silenced immune system. Okay, so we have our tumor, and our tumor expresses PD-L1. Okay, that's why PD-L1 was one of the things that we test for when we're trying to determine a treatment plan for these patients, because we want to know how strongly does the tumor express PD-L1. Okay, so we have PD-L1 on the tumor, and that binds to PD-1 on the T cell. Okay, and when PD-L1 is bound to PD-1, it deactivates the immune system, okay? So that's how the tumor cell can overexpress PD-L1 to deactivate the immune system. Similarly, we can have CTLA-4 binding to CD80 on an antigen-presenting cell, and when those two are bound, it deactivates the immune system, okay? So what would be a potential way to therapeutically target these checkpoints and restore immune activation? It's to develop monoclonal antibodies to either PD-1, PD-L1, or CTLA-4, okay? So the therapeutic drugs that we're talking here are going to be PD-L1 inhibitors, PD-1 inhibitors, or CTLA-4 inhibitors, because they're going to essentially take the brakes off of the immune system, okay? Does that make sense? Okay. So when we do this, we can usually restore the response that the immune system has to the cancer, which is a good thing. But we aren't able to refine that response just to the area of the cancer, okay? We kind of globally take the brakes off the immune system. And when we globally take the brakes off the immune system, we can see adverse effects that are resulting from overstimulation of the immune system in healthy tissue, okay? So this is basically showing you how the immune activation that we're getting can potentially damage healthy tissue, and that's where we get the main side effects of this drug class, which includes PD-1, PD-L1 inhibitors, and CTLA-4 agents, which are these immune-related adverse events. They're going to be very similar to the autoimmune diseases that you have learned about previously. And essentially, any part of the body can be at risk, okay? Tip to toe, anywhere we can see inappropriate inflammation, okay? The most common places are in the liver, the skin, the endocrine, so in the thyroid or the pituitary gland, and then in the GI tract with colitis, okay? But essentially, any of these can occur. The frequency of immune-related adverse effects, as I mentioned, tends to be a little bit more prevalent with our dermatologic side effects and our GI side effects. And the CTLA-4 inhibitors tend to be a little bit more, cause a little bit higher incidence and more severe toxicity than our PD-1, PD-L1 inhibitors. When we give those two drugs in combination, the toxicity is usually worse, okay? So take-home message here is that the most common organ systems affected are the skin and the GI tract, and the CTLA-4 inhibitors tend to have a higher incidence than the PD-1, PD-L1 agents. The severity of the immune-related adverse event can vary from very minor, like, you know, an increase in number of stools, but just only 1 or 2 above baseline, or a little bit of a red, itchy rash, all the way up to severe, okay, and life-threatening. So while these drugs overall are generally well tolerated, there are fatal events and fatal reactions that can occur, and so it's important to monitor for these severe side effects, okay? This just kind of gives you an idea of the organ system and what would be a manifestation of kind of mild toxicity versus severe toxicity. The good news is that most immune-related adverse effects are reversible. And again, that's with proper monitoring and intervention in a timely fashion. These side effects typically occur within the first 3 months, but we have to remain vigilant for them because they can occur at any time, and they can even occur after we stop the immunotherapy. Why do you think that is?
Because they're still activated.
Yes, the T cells are still activated. Excellent. So even though we stopped giving the immunotherapy drug, we didn't necessarily quiet the activated T cells, and we can't take all the activated T cells out of the patient's body immediately. So those activated T cells can still do their damage even though we have stopped the immunotherapy, okay? So we typically need to be vigilant for side effects up to 3 months after we stop the drug. The mainstay of treatment for these immune-related adverse effects is steroids, okay? You hear a lot about steroids in oncology. We do use a lot of steroids. So glucocorticoids are the mainstay of treatment for these immune toxicities. Why? Because they rapidly silence the kind of widespread inflammation and suppress the immune system to kind of quiet down those overreactive T cells. The treatment of the immune-related adverse effects with steroids does not appear to reduce the effectiveness of the immune checkpoint inhibitors for the cancer. And that's an important counseling point because I have patients who are sometimes afraid to report these toxicities to us because they don't want us to stop their cancer treatment. And so they're like, I'll just deal with it. It's fine, right? But what did we say? These can progress to very severe, potentially fatal reactions. So it's important to educate our patients that this is not going to interfere with the effectiveness of the treatment against the cancer, but you do need to report these toxicities because they can be life-threatening. The dosing of steroids is typically 0.5 milligram up to 2 milligrams per kilogram of body weight per day. We tend to use prednisone initially. So for example, for your kind of classic 80 kilogram patient, we might use anywhere from 40 to 160 milligrams of prednisone daily. We typically will start the patient on that higher dose, maybe 1 to 2 milligrams per kilogram per day, and then we will gradually taper the patient down over the course of 4 weeks. Some immune-related toxicities, such as pneumonitis and hepatitis, require a longer taper because what we see is if we try to taper them off too quickly, that immune-related toxicity flares. The patient becomes short of breath again, or the liver function tests start to increase again. As a pharmacist, this is a really important supportive care slide. I would highlight this. I might test you on this. Why? Because I know you're not all going to go into oncology and you're not all going to be treating patients with lung cancer, but you are all going to be dispensing steroids, and you should all know the toxicities, both short-term and long-term, of steroids. And this spans a number of different disease states, not just oncology, okay? So these supportive care things are things that I would expect you to know and to take with you on rotation. What do we worry about? Chronic immune suppression can increase the risk for opportunistic infections and infections, okay? So we might need PJP prophylaxis if the patient's going to be on an extended duration of steroids. We might need antifungal prophylaxis if the patient is going to be on an extended course of steroids. And we might need herpes zoster prophylaxis if the patient is going to be on an extended course of steroids, okay? We generally tell our patients to take these in the morning to reduce insomnia. I talked about that during chemo-induced nausea vomiting, right? And we generally tell patients to take this with a little bit of food, okay? So take your 40 milligrams of prednisone in the morning with breakfast. Patients who are on long-term steroids can get irritation of the lining of the stomach. So you might want to recommend patients who are having any stomach discomfort or dyspepsia to do a PPI or an H2 receptor antagonist if they're having any issues there. We also need to worry about prevention of osteoporosis. So we might need to make sure that our patient has adequate vitamin D stores, or if not, they're supplementing with vitamin D and calcium. And then for our short-term toxicities, for any of our brittle diabetics or our people who are pre-diabetic, we want to monitor blood glucose. And people who are on prolonged steroids can actually get adrenal suppression and undergo an adrenal crisis if we stop the steroids and they get sick, acutely sick. Have you guys learned about adrenal insufficiency and adrenal crisis? Okay. And then steroids, one of the really problematic things in practice is that it can lead to prolonged steroid use can lead to muscle weakness and atrophy. And so some of these patients need to maintain physical activity or work with a physical therapist. All right. When we grade toxicities related to cancer, and in particular immune-related adverse effects, we use a grading scale of 1 to 5, where 5 is fatal, 1 being mild, okay? So generally, the take-home message here is that for grade 1 immune-related adverse effects, we can usually continue the therapy and monitor the patient. But the minute that the patient crosses over into grade 2, that's when we're going to start our low-dose corticosteroids. If they have grade 3, we're going to increase or use a higher dose of corticosteroids. Or if we've had them on steroids for like 3 days and we're not seeing any improvement in the toxicity, we're going to need to use an alternative immunosuppressant, okay? And some of the alternative immunosuppressants you guys should be familiar with from your autoimmune lectures. For our grade 4, we are going to permanently discontinue the immunotherapy. This patient is not going to get any more immunotherapy treatment because this is now potentially a life-threatening situation. We absolutely need to have high-dose corticosteroids, and these patients are generally hospitalized. These next few slides are just a couple of the different organ system manifestations. How does the patient present? What are some things that are in the differential? And how do we manage? I think one take-home message here is that if you have a patient with steroid refractory colitis, you're going to want to start the patient on infliximab. Everybody know what infliximab is? Okay, so a TNF antibody that calms down the inflammation that we typically see in inflammatory bowel disease. Similarly with pneumonitis, if the patient's steroid refractory, we can also use infliximab. Another therapy we can see is IVIG. Again, we're just trying to globally suppress that overactive immune response. For hepatitis, we are not going to use infliximab. Why? Because infliximab has been shown to cause hepatotoxicity in some patients. So here, our steroid refractory option is mycophenolate. You guys learned about mycophenolate before? Okay. And for our endocrinopathies, it's going to really depend on where, like which endocrine organ and where the toxicity is occurring. But one important take-home message here is that some endocrinopathies are irreversible. So on a previous slide, I said that almost all immune-related toxicities can be reversible, especially if caught early. Endocrinopathies are the exception. We can burn out the thyroid. We can have immune-mediated destruction of the thyroid, similar to what you guys see in Hashimoto's thyroiditis. So you can see the T cells, the overstimulated T cells can actually totally destroy the thyroid, and the thyroid hormone will no longer make thyroid T3, T4, and they will have to be on chronic replacement. Similarly, we have caused type 1 diabetes in some patients where we have totally destroyed the insulin producing cells in the pancreas, and the patient has to be on lifelong insulin therapy. All right, so what, kind of to summarize things, what are the key take-home points when it comes to immunotherapy and patient education? One, it's important to tell the patient what the goal of therapy is, right? Our goal is to improve the quality of life and extend the quantity of life, okay? You want your patient to have a basic understanding of immunotherapy and how it works so they can understand why they might be experiencing these immune-related side effects. And you want to emphasize how important it is for them to promptly report symptoms. If we quickly identify toxicities, we can prevent them from becoming fatal. And you want to offer your patient reassurance that if we have to start steroids, it doesn't reduce the effectiveness of their cancer treatment. Also important to avoid live vaccines during immune checkpoint inhibitor therapy. All right, and then finally, for lung cancer in general, I want you guys to at least take this home. While yes, smoking is the biggest risk factor for the development of lung cancer, anybody with lungs can get it. I really think it's important to start breaking down that misconception because lung cancer is one of the most poorly funded cancers. So the NFL goes pink for breast cancer. Everybody does pink in October, and everybody knows about someone who's been affected with breast cancer. And I'm not trying to downplay breast cancer and its importance. It does affect 1 in 8 women. However, there's a lot of funding for breast cancer, a lot of organizations that do fundraisers and donations and a lot of resources and support out there. Lung cancer has a huge stigma because people think that smoking is a choice and that someone, if they choose to smoke, somehow deserves lung cancer. Nobody deserves cancer, first of all. And second of all, I have many, many, many patients who have never smoked a cigarette a day in their life and they still get lung cancer. So I just want to start breaking those barriers down because I think it'll really improve the care of patients. We have 2 broad classifications, small cell and non-small cell. Our more common is which one? Non-small cell, exactly. Which one's most heavily associated with smoking? Small cell, good. Non-small cell is extremely heterogeneous. Your treatment planning depends on the stage, the PD-L1 expression, and the molecular drivers. But if I have an EGFR or ALK mutation, do I care about the PD-L1 expression? Good. And immunotherapy has really changed the treatment of lung cancer. It's improved outcomes in many settings, but immunotherapy comes with its own unique toxicities and management. And as pharmacists, it's really important for us to know about these toxicities. You may not ever work in oncology, but I guarantee if you work in an inpatient hospital or you work in any emergency department, you're going to encounter patients that are presenting with these toxicities. So it's important to understand how to identify them and then the management. I'll take any questions I can say for a little bit after if you guys want to come up and ask. And if you have any questions, I believe in your syllabus, you have my email. Feel free to email me before, I think your test is what, next Friday, the 4th? So you can email me up till I would say like Thursday morning. I probably am not fast enough in responding to emails that if you email me sometime later today on Thursday, I'll necessarily get back to you by Friday. Hi there.
Thank you for the lecture. So why is the
PD-L1?
not being able to be tested in the liquid something?
Oh, that's a great question. That's a great question. Because it's just fragments of DNA that are shed and not necessarily the full cell. Right, and the PD-L1 is a cell surface biomarker. So if you think of your cell, it's one of the biomarkers that sits on the top of the cell. we don't necessarily have the whole intact cancer cells. We kind of have like fragments of DNA. So we can see what's inside the cell, the DNA, the molecular mutations and things, but we may not necessarily be able to see the PD-L1 expression. Does that make sense? Okay, and similarly, we don't necessarily have the whole like architecture of the tumor itself, which is why we can't see the histology, because it's just, again, these fragments of the DNA inside. That's like, because when you're pulling out blood, you're taking like 10 milliliters of blood, you're mostly seeing normal, healthy blood cells, okay? Mixed in there is going to be just some fragments of cancer cells that are being shed. Some cancers are higher shedders than others, and we don't have a way of knowing that, which is why when we talk about that sensitivity and that specificity, the sensitivity is not 100%, because there may be a patient whose cancer just isn't shedding a lot of DNA into the blood. And just because we don't find the
But it's not
mutation,
there,
it
doesn't
doesn't
mean
mean it's
that
not
it's
there.
not there.
Exactly, 100%, correct.
And when you say that we cannot tell, like, you cannot tell, like, even within a very specific cancer, you cannot tell if this patient is going to have a non-shedder.
Yeah, you can't tell. You just know,
even
you have
like
no idea.
Two persons with the same cancer, and then one.
Exactly, you would have no, it's very patient dependent. We look, because the one thing that we do know is that the more widespread the cancer, the more sites that are potentially shedding, the higher the chance that we're going to find cancer DNA.
Hmm.
But so we don't do liquid biopsies for people with like stage 1, stage 2 tumors, because those tumors are just like one discrete little tumor.
The likelihood of finding.
It's not, yeah, exactly, like that cancer hasn't even spread through the bloodstream yet, so it's unlikely that it's shedding. So this concept of liquid biopsy is really only used for like our stage 4 and maybe our late stage 3 patients to see if they're shedding. Because the cancer generally has to have kind of like already sort of spread in the blood to be able to be shedding DNA into blood. It's a very sophisticated question.
Thank you. Thanks.
Thank you.